Thank you so much for having us. We're excited to present our proposal to the Commission for how to best facilitate cost savings and promote the public good through the enrollment of Department of Corrections inmates into Medicaid. I'm Kira Crown. This is Maxwell Rupersberg, Mary Stottle, Flora Joe, and Rory Tukalski, and we're master's students in Public Administration and International Relations at the Maxwell School for Citizenship and Public Affairs. This is an overview of what we'll be covering today. We'll start by identifying the problem, then explain our goals, our plan, some expected outcomes, some potential challenges and key assumptions we made, and then we'll have time for questions. So though the Affordable Care Act allows for the partial coverage of prisoners' health care costs through Medicaid, the state penitentiary system is currently not taking advantage of these federal funds. Instead, it is paying for 100% of prisoners' health care costs, and this equates to roughly $223 million annually. We estimate that about half of this cost is incurred through hospital visits lasting more than 24 hours. Further, the Department of Corrections and state's Department of Community Health, or DCH, currently have no formal working relationship or system to streamline prisoners' Medicaid enrollment. Both also face a lack of capacity of staff and information systems to process additional applicants in an efficient and timely manner. Now, Flora will explain some of our goals.
So we came up with 3 goals that we wanted to achieve with the use of this grant. So number 1, we want to reduce DOC spending by taking advantage of the Affordable Care Act, which now allows the state to enroll the inmates to the Medicaid system, which under the funding scheme, the federal government will pay 90% of the costs. Second, we want to increase the collaboration between the 2 departments, DOC and DHC. So we understand in order to implement our program successfully, it requires a higher level of communication. Therefore, we're suggesting to hire some new professionals to facilitate with this effort. That person or that group of people can help with communications between the 2 departments and also interactions between the 2 departments. So the last goal that we have is to increase the capacity in the DOC to accommodate the increasing number of inmates that will be enrolled in the Medicaid system in the states. We understand it is important for us to increase the current technology capacity because it will ensure both departments will be able to operate at effectively and efficiently as the workload increases. Now I will turn to Max to talk about our plans to achieve those goals.
Thank you. So, in order to achieve these goals that Flora's outlined and to create a program that has a long-term success for the state, we've created a plan that has 3 major points. And the first point is to hire a DOC program manager. And their role will primarily be to oversee the creation and future implementation of a new system of referrals that will allow us to enroll the state's inmate population onto state Medicaid rolls, the federal Medicaid. They will also serve as a liaison between the DOC and the DCH in order to encourage communication between the 2, ensure that there's collaboration, and part of their role will be initially to conduct a system audit to identify gaps in communication that exist and ways that we can improve collaboration between these 2 departments because it will be very important for the success of the program. And additionally, they will also serve to oversee the retraining of any staff in order to function within this new system of referrals. There's just a little bit of retraining on the current functions that they serve that will be necessary. The second step is very crucial, and that involves enrolling the prisoner population in Medicaid. Because such a large portion of the DOC's healthcare expenditures result from hospital stays that last longer than 24 hours, we wanted to create a program that prioritizes those most at risk those most likely to incite costs for the state and for the DOC. So to do that, we created a 4-tier program in which the first tier, we target those inmates who are currently hospitalized. If they are not already on Medicaid rules after they were introduced into the hospital system, we want to ensure that that is taken care of immediately so that any current costs that they are incurring are being covered by Medicaid. The second tier is to target the highest at-risk members of the population. And what that means is the oldest 25% of the population, members of the population who suffer from chronic health conditions that we know will likely send them to the hospital, like asthma, or issues of the heart or liver. And lastly, any individuals who have suffered a hospitalization event within the last year, again, if they are not already on Medicaid. The third is a very important aspect of this program, which is to ensure that all incoming inmates are added onto Medicaid. And this is an important part of the new referral system that we'll be creating. So that as anyone comes into the penitentiary system for the state, they're being added onto Medicaid so that in the event of any future health crisis, they already have access to those benefits in the event of needing them. And lastly, the fourth tier of that is our current population of inmates. Because that's lesser priority, that's going to take place over a longer period of time. And Rory's going to discuss that timeline in just a moment. But finally, the third point of our plan is to improve the information technology systems used by both the DOC and the DCH. And primarily how we want to start doing this with this grant is by hiring an IT consultant and engineer who can do a system audit of the technology that's currently being used and identify the ways in which it needs to be improved, so that both departments can have a compatible system so that the DOC's digital records will work in function with the state's DCH system for Medicaid, so that there's cooperation and, again, technological compatibility. That's a very important factor. And so I'm going to turn it over to Rory to discuss the timeline and the expected outcomes.
Thanks, Maxwell. So we have a timeline broken into 3 major parts. Under our plan, our first priority is to ensure the liaison between the departments and begin the bidding process for the IT consultant contract so that we can get the system in place and moving by January 1st, 2016. Starting in January 1st, 2016, we expect to have the capacity to target tiers 1, 2, and 3. We will be immediately enrolling all inmates who enter. And then by July 2016, we expect to have the highest risk inmates, as well as those already in the hospital system enrolled in Medicaid. Under our tiered system, this strategy is going to allow us to realize the majority of the cost savings by shifting to Medicaid at the beginning of the program by targeting those that will be incurring the costs immediately. Thanks to that, that's going to give us more funding and more flexibility to implement the further inclusion of our 4th tier in the more immediate term, because we will be saving most of the money and opening up funding to expand our program and expedite the process. By the end of 2018, in the 3rd part of our program, we expect to have all inmates in the penitentiary system enrolled in Medicaid. Next slide, please. Thank you. With this timeline, we expect to realize both short-term and long-term goals. In the short term, we expect to see significant cost reductions inside the Department of Corrections by reducing by half the expenditure on health care for inmates. This is direct taxpayer dollars that will be saved year to year. Additionally, in the short term, we see strong capacity growth both in the DOC and the DCH in technology to enroll incoming inmates and introduce them into the system. This is going to be done through our liaison as well as our IT consultant, and under these 2 things, we're going to be developing a program that enables us to quickly get this system going and the capacity grown. In the longer term, we see more cost reduction, but in a different sense, at a greater scale across the state. That cost reduction is going to be mostly realized. Most importantly, we're going to see inmates remaining on Medicaid after they leave the prison system, and that's going to enable big savings in the state health system by reducing the most costly portion of state health care, which is costly unnecessary ER visits. When these people are still in the system and on Medicaid, that's going to be big savings for the state in the long term down the road. In addition, conversations with DCH has shown us that the reimbursement rate for Medicaid will be above the current rate that the Department of Corrections is paying hospitals for service. And we see that as a great opportunity for, to grow the strength of our hospitals in our state, as well as create opportunities for better care. On the long-term side, we also see social benefits. Experts indicate that keeping inmates on Medicaid will allow them to stay in the system once they leave prison and will reduce recidivism, which will have ripple effects across all agencies inside the state. Now I'm going to turn it over to Mary to talk to us about some of our challenges.
Thanks, Rory. While we are confident in the outcomes of our plan that Rory just described, we also do recognize some potential challenges and some assumptions that we are working under in developing our plan. The first challenge that we recognize is political feasibility. We recognize that it's often politically unpopular to channel funds into prison populations over other social services, such as helping veterans. However, as Rory just discussed, our plan has significant cost savings for the taxpayer and also social benefits that will affect people throughout the state. We recommend that we highlight both of those social benefits and cost savings to both government officials and the public when we are trying to implement and sell our plan. The second challenge that we see came up through conversations with the DCH, and it regards limitations on the current Medicaid eligibility and enrollment system. And we're cognizant of the fact that our current plan is going to greatly increase the workload of DCH staff who are currently overburdened as it is. In order to overcome this plan, we propose that our program manager, in conjunction with our technology expert who we are going to contract, will work with DCH and assist them in applying for federal matching funds to improve Medicaid eligibility and enrollment systems. There are 90-10 federal matching funds that are available until December 2015. That is why we are going to focus on this portion of the plan immediately, so that we are able to start enrolling inmates in January of 2016. If we are able to secure these funds, this will have great impact both on the speed and accuracy of our inmate population's enrollment in Medicaid, but also for all members of the state who are applying for Medicaid, as it will assure more efficient and speedy eligibility determinations and enrollments. Finally, we are operating under two critical assumptions in our plan. The first is that we will be able to utilize some of the cost savings that our plan will incur to develop, maintain, and implement some of our strategies that will be developed through the initial $100,000 of grant funding. This assumption is supplemented through conversations with the director of the DOC. Second, in order to achieve our cost savings, we are operating under the assumption that the majority of inmates are eligible for Medicaid, which we believe is a reasonable assumption since under the ACA, formerly ineligible populations such as single adults and childless adults are now eligible, and that is a great proportion of the inmate population. We firmly believe that our proposed plan will achieve the dual goals of increased social benefit and also reducing costs for the state. Thank you very much for your time, and we now open up the floor to any questions you may have.
Can we talk about the cost breakdown a little bit? So correct me if I'm wrong, so we're hiring a project manager, we're doing some business process redesign, we're hiring an IT consultant, and then might see the need for some PR in order to overcome the political feasibility. Can you just a little bit more specific with the numbers of where do you see the $100,000 going, and where do you see the rest of the money coming from?
Yes.
So we've thought about allocating $40,000 to $45,000 to pay for the salary for the program manager. We also looking in the $20,000 to $25,000 range for the IT consultant. And we wanted to use the remainder of those funds to handle these kind of program audit processes.
Yeah, and the IT consultant would be short-term, so we're not looking at a longer term.
Right, and the idea and that I mentioned at the end, is that we are hoping to immediately free up some of the current DOC budget because we'll be saving a significant proportion of what they currently spend on healthcare. And through conversations with the DOC director, she said if we were able to free up some of that budget, funds would be able to be shifted that we could use to further implement strategies. So we would use those funds for the PR campaign and continued technology and systems development.
So what are your expected savings?
So, under our program, we see an opportunity for expected savings up to $103 million. Max has more specific data on breaking that down for us. Max?
Sure, so the way that we came up with that number was using the data that we were given, which is obviously part of what we're working with. And we looked at the percentage of inmates in that sample that have hospitalization stays longer than 24 hours. Then we took, the average cost of those stays rather than those under 24 hours. And those over 24 hours are the ones that can be covered 90% after 2020 by the federal government. And it was 68% of hospital stays in that data set that stayed longer than 24 hours. So when we took the average, multiplied it by the 5% of the population in the state that is going to be hospitalized on average each year, we came up with a number of $112 million. And then, counterbalancing that with the eventual downgrade to a 90/10 payment plan, we thought it was more conservative to suggest around $103 million. And that's obviously an upper end of our savings, presuming again that the majority of our population is eligible for being enrolled on Medicaid.
So did you do the comparative analysis around what our short and long-term opportunities are around the other proposal?
Yes, we did. So we came up with a number that was actually greater for the veterans proposal, $127 million savings to the state. However, that was assuming we could shift all current veterans who are on Medicaid to the VA. And we discussed that that would be a significant limitation and that we could, with the current funds that we have, do some sort of PR campaign, but at the end of the day, the onus is on the veteran to switch, not in our control. So this plan offered more direct, tangible results in the short term.
I think we're good. Thank you.
Thank you very much.